Now I'm going to move on and talk a little bit about where does the money go, just because there are some misperceptions that I think that are out there that I'll try to address in the time here. Again, I have nothing to disclose, no financial relationships. And the reason why physicians are underneath such scrutiny for this is because of the healthcare costs, and it's unsustainable. The healthcare costs in the United States, the growth of GDP is going up, and people go, where's all this money going? Where's all the costs going? And so the first thing they do is, it must be those rich doctors. Those guys are driving the nice cars, living in the nice houses. They must have some part of it that's doing this. And it's terrible when you see even data from the Institute of Medicine. This is their 2010 report. It says in 2009, out of $2.5 trillion spent on healthcare, a third of it, $765 billion, was wasted. Wasted. Spending it on things that had no benefit to patients. And when you look at the cost, a quarter of it was unnecessary services, using beyond evidence-established levels, choosing unnecessary higher cost choices. Wow, that's pretty damning, and that's why we have papers like this. This is USA Today in June of 2013. It says doctors perform thousands of unnecessary surgeries. In fact, they're quoting a neurosurgeon in New York who says basically 1 in 5 surgeries in New York, in neurosurgery in New York, is done unnecessarily. The problem is that when you start looking at what she defines as unnecessary, you start realizing that it's a difference of opinion, right? So, for example, using a pre-made cranioplasty construct for the skull fracture that costs $5,000 versus a cheaper PMMA, like the case we saw yesterday at meeting, using PMMA and wires instead of more expensive implants. 5 different ways to do a procedure is what we came up with when we presented a case. None of us had a financial interest in that situation, but there's 5 different ways. 4 of you were doing it inappropriately by doing a higher cost procedure than the guy who would do it the cheapest overall. That's the issue. And so when you really start digging into the data, you realize that that's why there's no easy answer, is because there is no smoking gun. There is no, hey, this group of people are doing it unnecessarily, right? How many people here do unnecessary treatments, right? I don't see a single hand. Really? That's not what the data would show. 1 out of 5, and not a single person. It's kind of like hand washing. Someone's not telling the truth, right, overall? But the problem is that it's hit the newspapers even more. MSNBC, again, responding to Deo's paper, looking at risk of spinal fusion surgery, saying, look, we're doing more complex spinal fusions for common conditions like aging and arthritis versus simple laminectomies and decompression. And then we have papers like this, Wall Street Journal, this neurosurgeon in Oregon, right? Looking at multiple procedures, doing multiple surgeries over and over again. And he's actually one of the first people that they started noticing this whole trend with physician-owned distributorships. And that's why in July of 2013, you now have another young spine surgeon who's now on the front page of newspapers, U.S. News and World Report today. He was on CBS this morning, yesterday's edition, that talked about basically all these conflicts driving up the cost for personal benefit overall. Changing implants, changing the utilization of implants based on personal gain. These are outliers, and I totally agree with that. And what they did is wrong. However, that is not representative of our field and our group. The problem is that that's not how it's being perceived. And so the pitfall is things like Medicare will say, you know what, there's a lot of false billing. Look at this, we charged 91 people with $430 million of false billing. That's a lot. There's 865,000 physicians, countless more nurses, physical therapists, and other people. So that 91 people out of that representation, again, to me, that's an outlier system. The other thing is that some of the things that we do are taken out of context, like CPT coding and reimbursement. Each one of our CPT codes has a time component associated with it. So for example, lumbar fusion has 150 minutes of intra-service time associated with it. As we get better in our procedures, doing minimally invasive techniques, doing things that are now outpatient versus inpatient, those values don't change, but the problem is that they can be misconstrued, where now Washington Post looks at this, and this is their publication from July of 2013, saying, look at this, doctors working more than 50 hours in a day because the GI doctors are doing multiple procedures faster, easier. Ophthalmologists, orthopedic surgeons. What they don't put in is the advent of new technology and these patients actually benefiting from the procedures of doing something minimally invasive versus something that would have taken a lot longer to do. And it's getting scarier. So for example, Cincinnati doctor accused of performing unneeded surgeries. So now people are getting arrested for billing fraud. and this is now in the national papers. This one was posted on July 25th, 2013, for billing insurers for unnecessary procedures. Now becoming a criminal offense and people getting arrested now. Still, it's better than this. This is from yesterday, right? October 24th, 2013. So at least we're not to that point yet. But it brings up a common theme. These are people who are attacking doctors and nurses because they're angry over the cost and quality of care. So we cannot turn our back on this issue, even though it's not really within our purview. You know, as physicians, nurses, healthcare providers, we've trained to take care of people. We're not trained in business. But yet, these business decisions are what's driving us to these situations. So where's the money going? I guess that's really the big question. Where's all this money going? If there was a simple answer, we would have it by now. The problem is that you have to look at the Medicare coverage basics. So part of it is Part A, Part B, Part C, Part D. The Medicare payments that you pay in your paychecks only go to Part A, really. Medicare Part B, for physicians and the rest of us overall, come out of the general fund. There's a general, budget that's there. So one of the things is that it's a fixed pool. And so it becomes diluted. The more people in Medicare that you have, the more work that's being done, the more patients are being taken care of, the less the money has to go around. So you have to see a cut because it's the same pie. Medicare is enrolling on an average of 10,000 new patients per day, okay? 10,000 new patients per day is what Medicare is enrolling because the U.S. life expectancy is hitting an all-time high. But there are criticisms saying, it must be physician payments because, we rank 37th in health status, and yet we're paying all this money for health care. And so it must be the physician payments. So we got to have physician payment reform because they're just doing more procedures than ever before that are unindicated just so that they make more money. And yet we're number 37. Well, let me kind of start off by saying we're really not 37. If you look at the World Health Organization health statistics, we are 37 overall, below Costa Rica, above Slovenia, et cetera. The problem is if you look at this closer, you start realizing, how many teenagers in Costa Rica say, Dad, can I borrow your car? I want to go pick up my buddies tonight and maybe go to a football game, right? How many gangbangers do you see in Austria? Do you have the Crips and the Bloods of Austria fighting each other like The Sound of Music or something, The problem, so if you risk adjust, so the whole key component is if you risk adjust, if you take away the things that we can't help people with, a gunshot wound to the head is not something we as physicians can really easily reverse, okay? A car accident at 70 miles an hour on highway is not something we can easily reverse. This is Oldfield and Snyder in 2006. When you risk adjust homicides and traffic accidents, you realize that for treatable diseases, U.S. actually has the highest life expectancy for things that we can actually take care of. Diabetes, COPD, heart disease, strokes. Now you start getting into things where we actually are saving lives relatively. Do we have more car accidents? Absolutely, right? In China, when there's a lot more, like for example, I went to visit my relatives in Taiwan, there's a lot of scooters and bikes, saw accidents, but no one dies from those, right? Maybe a bruised shin, maybe a broken arm, but at 70 miles an hour is different than that. So it's called a silver tsunami, and it only makes sense that we have an increasing population, which is why statistically, this is from the US Census, the group of people above age 65 are going to double by 2030 compared to 2000. The group of people above 85 is going to double by 2030 compared to 2000. So not only do we have an increasing pool of people that are using healthcare resources, we also know from an incidence standpoint, it goes up. This was from the World Health Organ that was published on low back pain across multiple areas through Europe and such, looking at incidence of low back pain by age group and sex. Irrespective of sex, irrespective of the region that they looked at, low back pain, lumbar spondylosis increases with age. So as our patients get older, not only do we have more of them, they're actually going to have more problems with their spine than ever before. And that medical utilization in those patients, this is based on CDC data, is also increased, meaning that a 70-year-old is more likely to call their primary physician for back pain than a 25-year-old who's never seen a doctor before to call a doctor for low back pain. This is why AHRQ, in their assessment of 1993 to 2008, noted that low back pain especially with ER visits and hospital stays, became the 9th most expensive condition in the older population, 65 to 84 and 85 and up. Huge explosion of people that actually need our services and our care. But it's not the main driver of cost. Even though there are a lot more people needing health care today, especially for spinal disorders, the main driver of cost is the dollar spent per beneficiary. Medicare used to spend about $151 per beneficiary in the 1960s. It's now above $8,000. So if it's not, so now we have a problem of increasing number of people that need health care, increasing number of people with spinal problems, increasing cost per person to take care of them. Wow, this is going to create this tsunami effect that we may not be able to overcome. And this is a report by the HCCI, Healthcare Cost Institute, published in 2012, that looks at the aggregate data, the 4 largest insurance companies, private insurance companies, and noted that the growth in healthcare costs, again, are driven by price, not utilization. In fact, if you notice, spinal surgery is the lowest utilization out of all the things that we treat. We don't treat people with surgery out of a context. Let me put it this way. For every 1.3 million new physical therapy visits, CPT code 97001, only 30,000 of them end up with surgery. Out of a growth of 8.3 million new chiropractic procedures being performed, only 30,000 of them end up with spinal surgery out of those. Ironically, if you look at the growth rate across the aspects, and again, new physical therapy visits, new and return visits, that's how we can call this out. What you notice is that the incidence of spinal surgery relative to non-surgical treatment is actually lower now than it was 10, 15 years ago, right? Isn't that terrible? We're doing less surgery now per patient that goes for non-operative care than 10 to 15 years ago, based on 2010 Medicare data from the physician supply or procedure. The problem is that spinal surgery is friggin' expensive. Spinal fusions leads one of the top 20 principal procedures of cost for both elderly and non-elderly. Blue Cross Blue Shield of Tennessee will spend almost 8% of their dollars paying for surgery alone. So even though we are doing less surgeries, we are charging more for each surgery. So the question is, maybe the money goes to doctors, right? Do we overcompensate physicians, higher fees paid to U.S. physicians, unnecessary care by even primary care doctors, right? It must be the physician salaries that are driving this overutilization. Not really. You have to remember, physician work is not salary. That's why when they look at these salary values, I always laugh because we're actually paid by CPT. We're piece workers, right? So that if you look at the CPT code from 1997 to 2009, ACDS has dropped by 38% of reimbursement by Medicare. Lumbar discectomies used to make $1,200 in 1997. You made a little less than $900 by 2009. Surgeons now have almost doubled their work, their RVUs, in the last 10 years, right? The average surgeon that used to work 3 days in the OR, 2 days in the OR, now is adding on a Saturday to do catch-up cases, staying later at night to catch up on those cases. We're working harder. Bernstein calls this, in 2009, he had a great paper, it's called Surgeon Income Homeostasis. And the whole idea is that if you drop physician payment a little at a time, you actually force them to work more because they don't realize where their money's coming from. So they do the only thing they know what to do to maintain their ability to pay their bills at the end of the month, which is work a little bit more so that they can keep getting the paycheck they're used to, because they don't know how to address this otherwise. Even the McKinsey Global Institute has noted that the price per utilization, that the cost of healthcare is coming from the increasing price versus utilization. So relative to all of this, medical care by physicians, nurses, healthcare providers is actually becoming cheaper. It is more cost effective now than ever before, just because you're paying less per incidence of care for the professional fees. So where's the money going? Remember I showed you this before? Downstream revenue. If you look at the margins that you bring in, all those facility fees and costs that we bring in, that's where the bulk of all the costs are really kind of coming down into. And this is just an example for the public data now that's on Medicare that you can actually go to the CMS website and download. This is Vanderbilt. I can tell you this is what the hospital is getting reimbursed. This is what our charges are, and you can rank it among all the other hospitals. Even implants, right? We get accused of spending a lot of money on implants. After 4 pedicle screws, right? After 4 pedicle screws, if I put in an additional 8 pedicle screws, based on CPT coding, I get paid an additional $1.08 in 2010 data. That's 14 cents a screw. That's not overpaying your surgeon, is it? 14 cents for a screw? And if I do a deformity T6 to S1 compared to L4-5 instrumentation, wow, you know, I get paid 11 cents a screw. That's not a lot. But the problem is, this is what the manufacturers are getting paid for their implants, $13,000, $33,000. It is actually this data that drove Medicare to look at the disclosure because they're like, you know, surgeons are smart people. We're paying them 14 cents a screw. They're telling us that there's a lot of unnecessary hardware being put in. Either they're total idiots that can't figure out that they're only getting paid 14 cents a screw for something that's not necessary to do, or wait a minute, manufacturers are getting paid $33,000 for all that hardware, and they seem to have a great relationship with the surgeons. We probably should make them disclose because I bet you there's something going on behind the scenes overall. And so you can see where some of these assumptions are coming from. The problem is that when you see papers like this about new hip costs, right? $13,000 if you go to Belgium versus $125. This is not professional fees. This is not what the surgeon gets paid. This is all the downstream effect that we see, whether it's drug prices like Lipitor in the US for the same brand name drug compared to the same name brand drug in another place, same dosing, we pay a lot more in the US. CT scan of the head in the US versus other countries, including Canada, Germany, etc. Average hospital cost per day. Holy cow. Look how much we're paying compared to all these other countries overall. One of the reasons in the US is actually that we have to think about, and one of the reasons why organized neurosurgery is so concerned about the healthcare reform is that it does not add a single cent to expand the care of patients. No more new doctors, no more new nurses, no more new physical therapists. All it does is increases the administration burden, which has grown tremendously since the 1970s. It has grown by 2,753% for hospital administrators alone compared to physician growth. In fact, Cowan in 2009 in his presidential address estimated that the cost that we spend for healthcare, for hospital administrators alone, almost equaled that of pharmaceuticals. Just what we pay for people at the hospital to administrate us. Wow, that's a lot of money. The problem is that there's a misguided perception of cost because all those costs are aggregated into the hospital charge. The irony is that physicians are actually on the opposite. Most people don't realize that for that lumbar discectomy, only 48% of that payment goes for your services. 52% of that payment goes for your medical liability and your practice expense, right? What you have to pay your secretary, your staff, et cetera. And so while all the other data is aggregated into hospital costs, so they're hidden, physicians are getting, in a sense, overvalued on paper when in reality we still have overhead to pay, right, to cover all that. That's why I'm saying that we can't lose the message. You know, this is something that Jack alluded to. If you look at the EQ5D, Urquell 5D, lumbar spine disease has one of the most disabling components on that. And so that's why we need to work on our value assessment, because if we just go by cost alone, we're going to lose the message. For example, lumbar stenosis, medical management is cheaper than surgery, but surgery is more effective, so that we have to calculate out the value to see what is the best for our patients. And we have to change the cost-based structure rank order to one that's value-based. It's almost like if you have a toothache and it's killing you, and you go to the dentist, he says, congratulations, instead of paying for a root canal, we'll just give you some Lortabs and some Amisol, and you go home, and in about 2 months, your tooth will fall out anyway, so that when we do 3-month outcomes, you won't have any pain left. Is that really what is the best value for our patients with disabling pain, with disabling diseases? Or is it one of those things where you want to help them? And I know that I would fire my dentist if he told me, congratulations, you don't need a root canal, pat me on the back and send me out of his office. He'd be like, what are you gonna do about my pain? And if his answer was like, can't help you there, you know, pain management maybe, you know, I would not be very happy, nor do I think our patients are overall. Thank you very much.
So I'm going to talk about the timing of surgery on the value of spine trauma care, and since I don't know anything about business, this is going to really be a science and management type of thing. My disclosures, there should be nothing relevant to this particular talk. So these are really the five, I think, sort of categories we can kind of park our spine trauma patients into. Those with an incomplete spinal cord injury in the cervical spine, an incomplete spinal cord injury in the thoracolumbar spine, the complete spinal cord injuries in total, the central cord type syndrome that I think comes out a little bit differently and needs to be treated differently, and last of all, the unstable fracture that needs to be fixed but with no spinal cord injury, and again, looking at the timing of management of these particular injuries. So starting at the top, let's look at the cervical with incomplete spinal cord injuries. And again, all these are real cases that have been kind of, that have come through here, and most of these relatively recently. So this is a 31-year-old male, high-speed motor vehicle collision. He has a large scalp lac, but otherwise has no other injuries. And on his exam is noted to have, the exam is noted here with an incomplete spinal cord injury, some weakness in both upper extremities, essentially a flaccid right lower extremity, and some weakness in his left lower extremity. And you can see his images here demonstrating bilateral jump facets with some stenosis through his canal. And as these typically tend to be, maybe this is a little bit exaggerated, but they do tend to come a lot at Friday night at 10 o'clock at night. You're going into the weekend, and the question for these patients is, do we need to do anything for this patient right now? Can we sit on this overnight? Can we sit on this over the weekend and deal with this Monday morning when everybody's back and you have your regular OR staff and stuff like that? So I think let's go back to the literature, and I think this is an article that hopefully most of you are familiar with, and if not, probably a good article to read. The Stenosis study, this is available to anybody. You don't have to have a subscription. They published it in the open access because they want this to be available to everybody. 313 patients in 6 centers in North America, and when they broke down early and late, they defined it as 24 hours versus more than 24 hours. And really, when they broke down the early and late, it came out to 14.2 hours versus 48.3 hours. And really, the highlight here is if we look at the early versus late surgery group, there was a greater than 2-grade AIS improvement in score with an odds ratio of 2.83 in the early versus late. Didn't play out quite as well for a 1-grade improvement, which is a little bit interesting, and you can see the highly statistical value here. And their conclusion is that decompression prior to 24 hours after spinal cord injury can be performed safely and is associated with improved neurological outcome, defined as at least a 2-grade AIS improvement at 6 months follow-up. If we look at this another way, this is kind of the chart from their table, and you can see again this 2.83 odds ratio of 2-point improvement in AIS grading. Here's another one that really comes out with almost the exact same statistics. If we look at this one, it's 2.83. This is obviously a smaller study out of Australia looking at timing of decompression, again using a lot of the same statistics of 24 hours, and again we see that this has a 2.8 odds ratio of an improvement of 1 or more grades in the Asia grading pattern. Here's another article that came out recently. This is a current practice in the timing of surgical intervention in spinal cord injury. This came out in 2010. And again, looking at the conclusion here, this is 971 spine surgeons. The majority of spine surgeons prefer to decompress the acutely injured spinal cord within 24 hours. The majority of spine surgeons prefer to decompress patients with complete or incomplete within 24 hours. And again, very early decompression should be considered in patients with an incomplete cervical spinal cord injury. So again, I think all the literature that is all recent, all within the last 3 years, points to the fact that early decompression, early management of these patients is really critical and really can can affect the patient's outcome. So if we go back to our case, well, we took this patient as soon as possible for a closed reduction. Obviously, this is not a great film, but this is kind of what you see when you do your closed reduction. Patient goes straight from a closed reduction to the MRI scanner. We can say that now this patient is decompressed. Maybe we could do better, and obviously this patient hasn't been stabilized. But if you look back at the Stenosis article, this would be defined as the time of that reduction is the time from the injury to the time of the reduction would be the point at which this patient was decompressed. And obviously, shortly after that, straight to the OR for fixation, this patient had a single level ACDF. And if we look at this patient's exam, he's an incomplete injury, so he kind of goes from an Asia C-ish status to Asia D. He gets 100 points on his motor score, but he still has some clumsiness, so he's not really back to normal again. But we can argue that potentially the role of timing of this patient had an impact on this patient's outcome. What about the thoracolumbar with incomplete spinal cord injury? So here's a patient, a 56-year-old female. She's got diabetes, she's an alcoholic, she's got hypertension, has a ground level fall, and we can see this injury occurring here at her thoracolumbar junction. We can see this weakness bilaterally in her lower extremities. She still has some function here, but clearly has some deficits here. So if this patient comes in on Friday night at 10 o'clock at night, do we need to do anything with this patient now, or is this a patient we can sit on through the weekend and potentially deal with on Monday morning? Well, if we go back to the literature, does Scaskis hold true for this? And I don't think we can really jump to that conclusion that look purely at cervical injuries. We do not know if that holds true for the thoracic and lumbar spine. So I don't think we can extrapolate to this. We have no human clinical data at this point in time suggesting that timing has a role in neurologic outcome. And again, emphasizing here neurologic outcome. So does it really matter then? Well, let's look at the literature that we do have. Here's a systematic review that came out in 2007 in the European Spine Journal. Their conclusions looking through the literature: early fracture management leads to less complications, shorter hospital stay, and shorter ICU stay with early management. Again, these are going to be recurring themes. They also found that early fixation results in improved clinical outcome, but we find that the effect on neurologic outcome remains controversial. There's no evidence that early versus late surgery impacts these patients' definitive neurologic outcome. Here's another one, another systematic review from 2011. They looked at 11 articles. 3 defined early as less than 24 hours. Interestingly, the other 8 defined early as less than 72 hours. And in all studies, they found shorter hospital stay, shorter ICU stay, lower pulmonary complications, and lower costs with early management in these patients. Some of these authors are the same here. They did another systematic review looking at early versus late stabilization. And again, same sort of outcomes, better clinical outcome with early surgery and those with polytrauma. And equally important, early surgery does not increase complication rates. A lot of people say that we need to wait on these patients, and yes, they need adequate resuscitation, but as soon as they're adequately resuscitated, early surgery is indicated in these patients. Here's one by Jens and Carlo out of here, looking again at a systematic review, looking at specifically at morbidity and mortality. They found reduced days on ventilator, reduced days in ICU and hospital, reduced respiratory morbidity, but really no evidence on impact on mortality. And again, this article did not look at neurologic outcome, but again, we can see these sort of recurring themes that are coming over and over again. So in this particular patient, given her issues, it took about 24 hours for her to get surgically cleared. We then took her to the OR, did this costotransversectomy type approach, decompressed her, and although she had some improvement on her neurologic exam, she continued to have some very subtle weakness into her hip flexors. What about the complete spinal cord injuries? This is a 34-year-old male. He's intoxicated. He dives about 15 feet off of a dock thinking he's diving into deep water. The water was shallow. He lands on his head, has this axial load type injury with a C5 type of burst, and he comes in and he's essentially complete. He's out of spinal shock to the best we can tell. So if this patient comes in on a Friday night at 10 o'clock, is this somebody we need to do something with in the middle of the night, wait till the next morning, or wait till later? So if we go back to the Scaskis article, interestingly enough, this particular case does kind of fall into that role, and because about a third of the patients in the Scaskis were Asia A patients. So I think we don't have decent literature, great literature on this, but I think we really have to put this patient back into this category, and really there is some potential, particularly as this guy is young. We also need to go back to the other articles that we've talked about, all of these that talk about less ICU stay, less respiratory complications, better rehabilitation, what all these articles have supported. So we come to the same conclusions that there's less urgency, I think, than the incomplete cervical spinal cord injury, and I think we have to, this is arguable, and I think we have to categorize our patients individually. This guy's younger, so probably somebody you want to do something earlier about as opposed to maybe the 80-year-old, but the issues remain the same with respect to ICU stay, hospital stay, ventilator stay, morbidity, and again, we have to come back to no evidence that early surgery increases complications. So in this particular patient, given the fact that he actually did come in about midnight on one night, we actually waited till the following morning, took him the next morning, did this front back procedure, and unfortunately this patient remained an Asia A C4 tetraplegic patient. The central cord syndrome, I think we really have to put these in a bit of a different category than the other incompletes or the complete type of spinal cord injuries. This is a typical patient that comes in, a 71-year-old male. He has a history of hypertension, coronary artery disease, PTSD, and per the, I'm only showing you a select film here, but per the imaging report, there's no fracture on this. There's no transverse process fractures, lamina fractures, or anything else that kind of complicates the picture to suggest there's any picture of instability. I think you could potentially argue that this patient does have a little bit of high signal here along his anterior longitudinal ligament and possibly some signal going here into that disc space that may suggest a bit of a hyperextension and some subtle instability through here. He's got a very classic exam with some a central cord type picture. 4s in his biceps and wrist extension, 3s in his lower motor upper extremity groups, and then 5s in his lower extremities. So if this patient comes in on Friday at 10 o'clock, do we need to take this patient directly to the OR, or is this somebody we can sit on and wait till Monday or till we have elective OR time? If If we go back and look at some of the studies that are out there, this is an article out of 2013, Evidence-Based Management of Central Cord Syndrome. They looked at 16 studies. They did find that there was superiority of surgery over conservative management, but in their study they found no difference in early versus late management as defined of taking the patient less than 24 hours versus waiting to a later time frame. This is another study that came out in 2010, a review of surgical intervention in the setting of traumatic central cord syndrome. This was a single institution, 126 patients, and they broke them up into 3 groups, less than 24 hours, the initial stay, and they didn't really kind of define it beyond that, and then those that were sent out and came back for a follow-up admission 3 weeks, 4 weeks, 6 weeks later to undergo some sort of decompression. They found a trend toward fewer complications and death in the early surgery group, those in group A or B, but they really didn't find any difference in neurological outcome with respect to this. And I think that this is probably the best study I think that's out there that I kind of hang my hat on as far as management of these patients. The urgency of surgical decompression, acute central cord injuries with spondylosis and without instability. And what they found in their systematic review that I think is really kind of a good way to manage these patients is, and I put the whole thing here in detail to just basically present their findings, it is reasonable and safe to consider early surgical decompressions in those with profound deficits. And again, profound I think is open to interpretation, largely the ASIA-C and persistent cord compression. And those that are less severe, that have come in, maybe they start out with grade 2 and within a few hours are up to grade 4 in their upper extremities. These patients can be treated with initial early observation with surgery, potentially at a later date, depending on extent and temporal profile of the patient's recovery. So I think we see those that come in that have grade 2s and they kind of stay grade 2 over their 6 or 12-hour ER visit. And I think those are the more profound ones. There's those that potentially say they couldn't move anything at the start, and within a few hours they're moving their upper extremities, and by the time they get through their ER course, they're up to grade 3 pluses or 4s and starting to show evidence of recovery. I think that those are really sort of the big differentiation that they're trying to break out in this particular study here. And our patient, this patient took a while to get some medical clearance. We felt that he was a bit of a lesser, really falls into the less profound central cord type syndrome, so we were content to wait on him. He went to the OR. This was a 3-day weekend, so he went on Tuesday after he did come in on a Friday. And on his follow-up, you can see the typical improvement that you would see with the central cord, where he regained significant function in his upper extremities, still some intrinsic weakness, but something that's very functional and what you would expect out of a central cord syndrome. What about the unstable fracture with no spinal cord injury? Do we have any urgency on these particular patients? Here's a 63-year-old male. He has atrial fibrillation and hypertension. He rolled his car 4 times up in the Yukon. Due to weather patterns, it took about 24 hours to get this guy airlifted down here to Harborview. On his exam, he has some very slight weakness to triceps in his left upper extremity that I don't think you'd be surprised at looking at this imaging. But for all intents and purposes, he's neurologically intact, but I think most people would argue that he has an unstable spine and probably merits some sort of surgical management. So if this guy comes in, what's our timing on this particular patient here? Well, again, I think as we kind of come back, we see the same sort of articles over and over again that say, yes, there's nothing neurological to worry about on this guy, but we do worry about ICU days, we worry about hospital days, we worry about costs and other complications that can occur with this particular patient. So again, we've seen this slide before, the same sort of issues that arise, and we want to try and treat this patient urgently, but maybe not in the middle of the night, maybe not necessarily on a Sunday morning if you can wait till Monday and he comes in Saturday night or something like that. And this particular guy, given timing, we actually did take him to the OR the following morning. He did arrive late at night at about 10 o'clock. Took him to the OR the following morning for a first start, and on follow-up he continued to have weak left triceps, but otherwise maintained his full strength and had a rapid hospital course and was back home again in short order. So in conclusions, I think as we break these out, cervical incomplete and complete injuries, not including central cord syndromes, the evidence suggests that we have better neurological outcome with emergent surgery, and that's defined as less than 24 hours for right or wrong within the literature. If we look at central cord syndromes, the evidence suggests that early surgery is indicated in the more severe injuries, but we can wait on those with less severe central cord syndromes to kind of see how they play out and maybe treat them a little bit more electively. In the thoracolumbar completes, incompletes, and in all unstable fractures without deficits, I think we want to treat these urgently to diminish ICU days, hospital days, morbidity, and costs, but we really have no evidence of the impact on neurological status or mortality. Thank you.
we talked about the deformity, talk about trauma. We can start something that we see more frequently in the community practice. Here's my disclosure, and I'm nothing special. And the radiculopathy is actually a spinal nerve dysfunction that can causing the dermatome pain and the paresthesia and the mild home weakness and the impaired deep tendon reflexes. The prevalence of the cervical radiculopathy is about 3.5 per thousand population, and then the lumbar radiculopathy is about 9.8 per thousand population. There are risk factors associated with the development of the radiculopathy. The occupational and the recreational factors are very important things to consider. And then the radiculopathy normally is contributed by the disc herniation and the spondylosis in the cervical spine and the lumbar spine. The soft disc normally occurs in the younger patient, is the acute herniated disc, and then in the elder patient, normally they develop this disc osteophyte complex that involves the facet joint, uncovertebral joints, and then disc calcification. In this patient population, the pain pattern can be complex. It involves the discogenic and the nerve radicular and even the facet-based pain components. Now, the natural history, the Weber et al. Did this study based on the Scandinavian population. It was found in the 208 patients without physical therapy, only had the bed rest for about 1 week. After 4 weeks, actually 70% of the patients had a marked reduction of the pain, and 60% of them returned to work. However, the recurrence rate was about 20%, and then in about a year, 30% will still complain of the pain, and 20% of them are still out of the work. Now, we all experience, and what is well published of this, the disappearing herniated disc. This is one of my patients, 36 years old, that I offered the surgery. Patient did not want it, and then in 6 months, the follow-up MRI shows the disappeared disc and have the clinical reduced symptoms as well. Now, for the cervical radiculopathy, based on the Lee and the Turner back in the 1960s publication, 45% of them just have a single episode of the recurrence, and then 30% has the intermittent episodes, and 25% can have the persistent symptoms. This publication by Gore studied the neck patient in about 205 patients. About 60 of them had the radiculopathy component, and after the conservative treatment course in 10 years follow-up, only 1/3 had persistent moderate to severe pain for the radiculopathy that portended a poor prognosis. The neck pain, however, obviously everybody knows is a variable outcome that usually gets better with the conservative treatment at time, but can also be influenced by the psychosocial factors. Now, the NAS, in order to provide some evidence-based clinical guideline, the NAS formed this developmental community. Their work group, based on the level of the data in the literatures, and put the grade of the recommendations in terms of the many treatment options. We'll talk about this later. And then for the both cervical and the lumbar radiculopathy, the conservative treatment can start with some like orthosis, and then can start the medication, including both the steroid and the non-steroid medications, and then normally they can progress with the physical therapy. Majority of the time, the home traction is prescribed. Now, after all this conservative treatment does not work, some sort of intervention can be taken by the physiatrist, like this trigger point injection and epidural steroid injection. It can be delivered through an interlaminar fashion, and also can be delivered into the transforaminal or selective nerve roots block fashion. And the cervical injection was actually found pretty powerful, and Lin et al. Published this data in 70 patients, and which found that about 63% the population can have a successful outcome that can avoid the surgery. This is similar in the lumbar epidural steroid injection literature, and which is the same has the same efficacy. Now, this was confirmed by the NAS, the work group statement, the transforaminal epidural steroid injection can provide the relief of about 60% of the population, and also in the patient who clearly have the surgical indication, 25% of them after the injection, you can have the short-term the pain relief that negating the need for the surgical intervention. These are obviously back up the very low grade of the publication is about level 4 evidence there. Now the South group published this the treatment algorithm for the acute radiculopathy in the cervical spine. The acute painful phases with 1 to 2 weeks, you can start the steroid, non-steroid pain medication, and the activity modification with some the cervical orthosis. For the intermediate, like 3 to 4 weeks, you can start the physical therapy and home traction. And then after 4 weeks, then you can start the steroid, the injection, and some ergonomic changes as well. Now, after all this treatment, the systemic treatment, 70 to 80% they will have the successful outcome in about 2 to 3 months. That sounds very good. So people will ask the question, do we still need a surgeon? Now, remember, this is only like successful in the 70 to 80% population. How about those 20 to 30 patients that the percent of the population that is not successful after the conservative treatment? And the same studies confirm. This one is published from the Mayo Clinic in the Minnesota, which studied the 563 patients. After the 5 years follow-up, there's a 30% of the recurrence rate and about 25% who's not responding to the conservative treatment and underwent the surgical treatment. That's where the surgeon plays the role in this the treatment of the radiculopathy. Now, in general speaking, the indication for the surgery, including the failure of the non-surgical therapy for a defined length of the time, usually is about like 6 weeks to 3 months, and also the non-improving the neurological deficit, severe and incapacitating the pain for shorter time frame. Persistent pain or paresthesia with or without a neurological deficit, and the progressively neurological deficit, the myotomal weakness. Although it's widely debated, all these the indications, there's only one absolutely indication for the surgical intervention, that is a documented progressive neurological deficit with the myotomal weakness. Now, this group of patients is actually a small minority of the surgical candidates. The other indications, including the severe incapacitating the pain for the shorter time frame, with the persistent pain or the paresthesia with without the neurological deficit. These patients are always cannot be controlled, the pain, without the high dose of narcotic medication. Based on the NAS work group statements, the surgical intervention is suggested for the rapid relief of the symptoms, and when compared with the medical and the other intervention treatment, and this received the level 2, 3 literature support. The last one is the failure of the non-surgical therapy for the defined length of the time. Usually is about 6 weeks to 3 months, or non-improving neurological deficit. In actually practice, this patient population appears to be the most common indication for us surgeon to decide to proceed with the surgical intervention. Now, in generally speaking, the goal of the surgery for the radiculopathy is the decompression of the nerve roots, eliminate the radiculopathy, and decrease the mobility, and also elevated the component of the neck or back pain, and obviously to maintain the spinal stability and the biomechanic function is very important as well. Now, for the lumbar, if there's a medial the herniated disc without any instability, and obviously you can perform the open or the minimally invasive surgery, and for far lateral disc herniation, the minimally invasive surgery obviously is better choice. And then for the one with the instability, the fusion is needed. You can achieve the stability again. Now, for the cervical spine, if you have a broad-based disc herniation or bilateral disc herniation, obviously the anterior cervical approach is a better choice, and then you can have the discectomy and the fusion, or you can have the discectomy and the disc, the arthroplasty, like Dr. Ziegler talked about. And then for both procedures, either the discal arthroplasty and the ACDF, you can achieve the adequate decompression by directly decompression and the indirect decompression. Direct decompression by remove the disc and also by remove the ankle-vertebral osteophyte, foraminotomy, etc. And then the indirect decompression is just by putting into the intervertebral device, either the disc or the cage or the bone graft. You can increase the dimension of the neuroforamen so that it can reach the indirect decompression. For the unilateral paracentral disc herniation, however, for those who cause the radiculopathy or mild myelopathy, the posterior foraminotomy and microdiscectomy seems better. Then in this way, you can avoid the fusion and the expensive the disc the replacement. Now, for the posterior foraminotomy, it's proved that it can directly decompress the nerve roots. It's a simple approach, and established the clinical efficacy for the open and both minimum invasive is about 80 to the 95%. Also, this can avoid the fusion and its complications. Now, it can prevent adjacent level disc disease as well. Based on the Clark study, which is studied in 300 patients, and this is an open procedure. In the 5 years and the 10 years, the adjacent segmental disc disease is about 3 and 6%, which is much lower than the fusion procedure. Now, surprisingly, for this in this study, the same segmental degeneration is very low. It's only 3 and 5% in the 5 and 10 years respectively. Now, the conventional foraminotomy, which is open procedure, and this advantage is that it often have the copious epidural bleeding, and it has a limited view to reach the far foramen, and then also it has to do extensive subperiosteal stripping of the paraspinal muscles, therefore can cause significant the neck spasm and then pain after the surgery, and then this is the time that the minimally invasive approach can provide the better the solution that Kevin Foley already spoke this morning. It can avoid the muscle stripping and the crushing, can limit the bony resection, and also can provide a direct surgical corridor to the target site with a better visualization. And the surgery can utilize a smaller paramedium incision to reach there. In terms of for cervical spine, in terms of the positioning, you can have the prone position, you can have the sitting position. The visualization too, you can utilize just a conventional surgical microscope or the endoscope. Now this is the typical the case how this is done, and then after you open the bony foramen and the window, and then you can see the dura, protect the dura. Then you can use the under the C6. This is C6 and the C6 nerve roots. You can use a diamond burr to shave down the ankle-vertebral osteophyte to achieve the decompression. This is my patients, which has both have is a young patient, have the paracentral disc herniation, only has the radiculopathy symptoms. So after failed conservative treatment, they went through this minimally invasive procedures, which has the excellent outcome. Now, based on the published data, the minimally invasive cervical foraminotomy can relieve the radiculopathy pain in about 80 to 92% of population. There are many studies in the past decades which shows that the minimally invasive approach for the cervical foraminotomy has the shorter length of the stay and requires less pain medication after surgery. And this is a different group study compared to the open and the minimally invasive procedure, except the operative time, which has no significant difference in terms of the blood loss, the recovery room pain medication, and the discharge pain medication, and the length of the hospital stay. The minimally invasive are significantly different from the open procedures. Now, according to the FASTLess data, this decompression effect can hold up to 2 years at least in terms of both the VAS score and the neck disability index score. Now, both anterior approach and the posterior approach has been compared. Based on this paper, it studied 100 patients with the conventional ACDF and the minimally invasive foraminotomy. It shows that there's no significant difference between the groups in terms of the revision or the complication rate. and both of them can achieve the equivalent outcomes for relieving of the radiculopathy pains. And then the posterior foraminotomy, however, can maintain the mobility of the neck. This has been proved over and over in many publications that according to the Vaqueros group, the ACDF yields satisfactory results in about more than 90% of the population, and the keyhole foraminotomy can achieve like a 96 good outcomes. And this was also supported by the NAS work group statement, which either the ACDF or posterior laminotomy or foraminotomy are suggested for the treatment of the single level, the degenerative cervical radiculopathy secondary to the foraminosoft disc herniation. For the lumbar spine, the radiculopathy, everybody knows the sports study, and although it's widely criticized the study, but nevertheless, it's the largest controlled trial to date. At the 4 years, after they released the 4 years result, it shows that the patient who underwent the surgery for lumbar herniated disc achieved the greater improvement than the non-operative treated patients in all primary and the secondary the outcome except their work status. Now, today's talk are mostly regarding the cost effective. Torstenson actually used the same group of the patient from the sports study, used the same cohort at the 2 years and the 4 years. What they found is at the 2 years, the lumbar discectomy compared to the non-surgical management was felt to be the cost effective, with the cost of between like 35,000 to 70,000 per quality, depending on the payers. And at the 4 years, the cost per quality of the surgical intervention was actually dropped to about 20,000 per quality. This is simply because that the benefits of the surgery was durable and held up against the time. Now, similar study was published a year before this, which is the Hansen's group. They studied the 1,800 the workers with the medical disability for at least like 4 weeks, and then what they be able to in this group, there's 92 patient who underwent the surgical intervention for the herniated disc, and then they selected another 92 patients with this equal or similar background for the comparison. What they found is that the cost per quality of the surgical intervention is about like 4,600, and then reported that the surgical treatment has better cost utility than the non-surgical treatment. And the gain in the quality was 10 times higher among those that received the surgical treatment, and the total cost for surgery was lower due to the lower recurrence rate and the fewer disability. What their conclusion is very simple, that the surgery for lumbar herniated disc was cost effective. All these data lead to this updated the NAS, the evidence-based treatment guideline, with the first statement says that the decompressive surgery is suggested to improve the outcomes in the patients with moderate to severe symptoms of the lumbar stenosis. And the second is that if the patient is predominantly with the leg pain, which is radiculopathy, the simple decompression without the instrumentation fusion will be adequate. And then all these are backed up by the level 2 or level 3 data in the literatures. Now, in summary, the surgical intervention seems to provide better outcomes when compared with the non-surgical management in the patients that failed a appropriate 6 to 12 weeks conservative treatment, and then the obviously radiculopathy pain is more reliably relieved by the surgery when compared with the neck pain and the back pain. Now, at least now, the surgical intervention for the lumbar radiculopathy is proved to be cost effective. We are still waiting for the data regarding the cervical radiculopathy. Thank you.
So there's some key facts that we should all know, and that is the musculoskeletal conditions will cause pain, physical disability, and loss of personal and economic independence, affecting millions of people of all ages and all cultures. And the second greatest cause of disability, as measured by years lived with disability, we learned this morning about the dailies. This is worldwide and across all regions. And ranks major causes of death and disability is the fourth greatest impact on the health of the world's population, considering both death and disability. So the dailies and the qualities are all over, and not just here. If you remove cardiovascular conditions, neoplasms, mental and behavioral disorders, musculoskeletal conditions come in number 4. And the current estimates of people affected worldwide, this was a publication in Lancet, that back pain, about 632 million people, neck pain, about 50% of that, and then osteoarthritis and other musculoskeletal conditions. So as we can see, that the burden of disease in the world is huge when it comes to these. So there's a vision of the bone and joint surgery, the bone and joint decade, and that is to have a world where musculoskeletal health is a priority and where the prevention, treatment, and the care will be of a high standard and consistently accessible in order to improve health-related quality of life for people who are at risk for musculoskeletal conditions. So to do this, we look at one continent that has most of the underdeveloped countries. To fill the human resource gap by brain drain in Africa, we are employing about 150,000 expatriates. That's $4 billion a year to do that. And of the 47 sub-Sahara countries, 38 fall short of the minimum World Health Standard for 20 physicians per 100,000. Now, I'm from Ghana, which is somewhere here, so we're part of it, and I'll give you some statistics later on. And there are some countries that are losing talent very rapidly, and there's something called the emigration factor, and it's basically said that it's made Africans very at a great risk. Haiti, 84% professionals live outside the country. I'm from Ghana, 47% of professionals live outside the country. And it goes all the way down. Most of these are African countries. This is Ghana. Ghana was a British colony. We got independence in 1957 from the British. It used to be called the Gold Coast. Population of 26 million people, the size of Iowa, pretty much. And about 172 hospitals, 35% by religious groups. This is the statistics in terms of specialties. For 26 million people, there are 15 orthopedic surgeons and 5 neurosurgeons. Now, we have 15 spine deformity surgeons at HSS alone. So you can see the disparity here. So we established this organization back in 1998 to build a sustainable infrastructure to deliver state-of-the-art orthopedic care and education. This was an 18th century Portuguese lighthouse. That's the structure in front of the hospital. And our mission is to provide optimum orthopedic care, improve quality of life that we've been talking about all morning, and expand capacity also, since there's a dearth of professionals. So critical facts and challenges that we faced are many. And I had a debate with my wife when we were thinking about forming Focus. And also, we're back in Minneapolis, and I said, honey, I think I'm overqualified. I can't go back. It will be too expensive. She said, well, then why don't you form something nonprofit? That's the way we can get around it. And I appreciate her wisdom. So the human resource challenge is huge. It's infrastructural challenges huge. Nothing, they don't exist. Utilities and equipment not available. Do complex orthopedic and spine conditions as well, all you're going to see, because the simple one's not going to come to anybody. They'll walk around with it. And then there's no money to treat anybody. And then to make it sustainable is a huge challenge. So I'll go through some of these. So I try to get beyond the human resource challenge by first inviting volunteers. So I had my friends and partners from all over the world. About 300 volunteers since we started have participated, and you might find yourself in this. So we have about 168 surgeon volunteers, 94 nurses, anesthesiologists. So you can see all the way across, even to research assistants have participated in these mission trips, about 500 mission trips since 1998. And that was the only way we can get past the volunteer. And these are volunteers who are also contributing their time and paying their way so that we don't have to have the huge cost of bringing people over. Plane fare alone is about $5,000 for round trip. So since we opened the hospital, we have 154 employees. 11 consultants. So now the next goal now is trying to build local capacity so that we won't have to depend on the volunteers all the time. And that's where we are now. Now, with the infrastructural challenge, these are two institutions. This was the General Hospital in Kumasi, where I was born. I was built in the 50s by the British, and nothing has changed. This is the Crown Hospital, which was also built by Governor Guggisberg in the 60s, and it also stands the same. Each one of them is about 2,000 beds, and patients still don't have room for beds to lie on. There's a poor maintenance culture, limited research infrastructure, and then utilities are also significant environmental constraints, inconsistent. This is our hospital, and basically we have this oxygen plant, so we can have centralized oxygen and nitrox. These are water tanks that basically supply the hospital with water from a well, 3 wells dug, because we don't have public water. So with the 3 wells, we get 25,000 gallons of water, and they all go through reverse osmosis systems. So I thought I was going to build a hospital not knowing that I had to become a water expert. And then, so our core purpose has been optimal patient care, education, professional development, and clinical research. And I'll show a video of what we've done so to date. Go ahead.
Today is a red letter day for focus, for it is the translation of a dream into reality.
When we hold him like this, does it make it easy for him to breathe?
With a vision, he came with a passion. He's somebody who set his sights on a goal and then had a commitment from a focused team from all over the world that he was able to lead with passion. He was able to say, follow me, and look what we can create. And today's ceremony is really the culmination of that vision and that focus.
a healer was a dream that I grew up with. Giving back was my mission. As we all know, growth was a real today. It's taken many years of hard work to build a hospital is great. To equip and staff it is great. But to love to be part of the dream, the bigger picture of the Okay, so that's where we are now. So the next challenge is the complex orthopedic conditions. So even though we're trying to help, we see conditions that are pretty much like out of this world because they are neglected. Nobody has tried to do anything about it. And will cost several thousands of dollars to treat them. When it comes to the spinal deformities, it's the most neglected of all the deformities that are present in children mostly. We don't see many adults with these conditions because they're not all around. They don't survive these deformities. So making the diagnosis and getting the imaging studies like MRI, CT scan is not always available to be able to do what we can. So this has been our philosophy. This is where I am, special surgery in New York Hospital. And here we provide excellent care. This is the Focus Hospital and the Kolebu. And we looked at, can we do the same thing, but what more important is relevant care and progressively and ethically improve the care that we're going to provide to these patients. Now, excellent is a state of being superior, but relevance is applicability to real-world issues based on what you've got. So you can have a chest tube apparatus here, which is like $1,000, or you can make your own chest tube with 3 bottles and reusable, which is about $15. And it's all it's relevant, and it does the same trick. So we've also instituted best practice guidelines and processes for improvement, adhering to strict perioperative protocols in patient safety, health information systems, PAC systems. We're actually on this ICD-10 coding, orthopedic registry and databases, a multidisciplinary team, an ambulance service to transport patients who are in dire need of other medical problems, intraoperative neuromonitoring by training local techs to become spinal cord monitoring experts, and then medical board and communities to run the operations. So today we have these specialties at the hospital, which making it a multidisciplinary orthopedic hospital, similar to what we have at HSS. And it's not only orthopedics, but we have neurosurgery, anesthesia, pediatrics, medicine, and all the others as you see here. The ones in yellow are permanent individuals, and the ones in white are basically consultants who spend time as part-time at the hospital. We've also been involved in professional development programs with the American Academy of Orthopedic Surgeons, the Ghana College of Physicians and Surgeons, this is their headquarters, holding annual seminars, summits, and in-services for the individuals. Translational research, something that I've been very interested and involved in all my life. Patient-oriented especially, this is our research team, aimed at enhancing the adoption of best practices also in the country. And surgical procedures to date, over 1,100 patients have undergone complex spine and orthopedic procedures. Last year was our biggest because that's when we opened the hospital, and have evaluated about 26,700 patients. A very robust surgical registry and database like we had this morning, because we believe that's very important to make it evidence-based so that we can know exactly what we're doing and can modify it with time. We've had several publications and abstracts presented at national and international meetings on all the conditions that we have come across and are still doing so. Recently, we were one of the 10 finalists at the SRS for the Russell Hips Award by reviewing an incidence and risk factors of major surgical complications in patients with complex spine deformity from an SRS GOP site based on the robust database that we have established. We looked at 427 surgically treated consecutive pediatric patients from December 1998 to 2012, a prospective radiographic and demographic data, pre-op and immediate post-op. We looked at risk factors like age, etiology, curve magnitude, osteotomy type, univariate and multivariate logistic regression, to see what was significant in terms of risk. We came up with a neurological risk of 6.1, permanent was 1.6, implant-related was 8.2, 1.4 mortality, tracheostomy was 1%, no blindness, and cardiac events. So these are very important because we believe that this is basically like the benchmark for doing complex spine deformities in third world countries. Looking at the univariate predictors for postoperative complication, three-column osteotomies was one of the risk factors, and then large curves over 100 degrees were also risk factors. So based on that, we've come up with a focused risk scoring criteria so that going into a case, we can label a patient as a level 1, level 2, 3, or 5, and then I can also match the surgeon with the operation. Using deformity characteristics, ASA, BMI, Asia score, fusion levels, osteotomy type, rib surgery, or disc surgery, and come up with a score. So we've instituted other methods like the TSRH type tension band traction system to reduce the need for three-column osteotomies by putting patients in traction for like 2 months, sometimes even 4 months. Make them flexible, make them nutritionally amenable to undergo complex deformity surgery, improve their pulmonary function, and do a very safe operation. This is an example of a patient who comes in with 3 curves, all were with over 100 degrees, 177 for one curve, 118 for another curve. PFT was 52%. This is after he's been in traction for 4 months. And we can see the improvement. If you had to take this guy back into surgery right away, you have to do three-column osteotomy, which we know is very risky. But after 4 months of traction, this is where he's at. And then this is him pre-op. And then after 4 months of traction, we can see the improvement even of his kyphosis from 173 to 126 degrees. Now, this is his score. So he scores 40 for deformity, 6 for ASA, BMI 8, Asia 2, fusion levels 3. And then if you do a VCI, he gets 20 more points. And if you don't do a VCI, he gets 19. So because of the traction, we're taking off 11 points off of his risk scoring. So he goes from 87, which would have been a high risk, or 76, which is a medium risk. And with that, any of my surgeons who are well-trained can do these osteotomies, SPOs, concave ribs, thoracoplasties, multiple rods, and get him good correction. Because we have been able to improve his deformity with the traction, we don't have to go to the high risk level by going to 87, by come to level 4 for him. And that's what was done. And this was so he had instrumentated fusion, T4, L4, SPOs, thoracoplasty, concave rib osteotomies, costal transverse discectomies, and that's him post-op with good results and no complications. And we figured that's the way to optimize care and also make surgery safer. The funding challenges have been many. In 2005, the government spent 6.2% of GDP on health, $30 per capita. That's not even enough for the suture that we're going to use to close the back, let alone the pedicle screws. 34% was government expenditure. So it's inadequate funding, lack of commercial insurance doesn't exist, affordability of quality care doesn't exist, high cost of doing business, and there's non-philanthropic culture also of the general populace. So for the 1,100 surgeries based on donations, implants bought at discounted price, we've saved the government $110 million in healthcare costs, which nobody could have been able to afford over there. So these 1,100 people either would be maimed, disabled, or dead. And this is because we've had very good cooperation of all these device industries, the Hospital for Special Surgery, and then also my own royalties go into the organization. And with that, we've managed to be able to help these patients have smiles in their faces and have a new lease on life. Thank you.